Hello, this is Laura Abbott, and we are here to talk about the Bionic Elder training with new hips or knees. And here is a picture so you can put a face with the voice. I teach at Georgia State University in the exercise science program, and at one point in my many hats that I've worn in my career, I was also a massage therapist. I'm not any longer, but this is just to kind of give you some information about me, and we'll just move that along. So how to get your continuing education certificate. You may be aware of this from previous programs you may have taken with us. And if not, you will also see this at the end of the presentation, so don't feel like you need to jot all this down. But you're going to complete the webinar, obviously. And then you can go to the Exercise Etc. website and click on the administration button so that you can get to the webinar on demand certificate link. You're going to choose the exact title of the webinar. We have several that are similar, so be careful and make sure you pick the exact title. And then you're going to complete a 20-question quiz that is required, complete a brief evaluation, and then you will finally get to the point where you can fill out your name and other requirements for the certificate. And you do want to make sure that you put the name down that you use with your certifying organization just to keep life a little simple. And save a copy of the certificate on your computer once it is emailed to you so that you can keep a record of it once you send it off to where it needs to go to get your CE. And remember to complete this webinar and print the certificate by December 31st of the same year that you ordered it, because some, some credentialing organizations will not accept certificates with next year's date on it, so we just want to make sure you're aware of that. And the webinar quiz is based on the printed material in this handout, not on the lecture itself. So the webinar quiz is sequential. It follows the outline, so it's not rocket science, but it just tests that you completed the course to show that you did go through the entire program, because WebEx does track if you log off early or if you fast forward, and because of that, sometimes you may not get your certificate. So we just want to make sure that you are aware of that and don't do that. So let's get into this webinar. So basically, there are going to be some similarities in assessing and training a client who has hip or a knee replacement. The goal of this workshop is to explain a step-by-step process for developing a post-rehabilitation exercise program. So there may be some of you who are listening to this who are physical therapists, who are licensed athletic trainers, and we know that you guys are able to do a lot more with a client for rehab than people like myself, who is not a PT or an athletic trainer, and falls into the exercise physiologist, fitness professional category. So we're kind of zeroing in on the life after physical therapy when it comes to this program. So be aware of that. So first thing we want to do is kind of go through the anatomy, and hopefully this is a review for you guys, but it's easy to forget some of the anatomy. So when you are looking at the glute muscles, sorry, attention deficit syndrome here. So gluteus maximus, gluteus medius, gluteus minimus. This is all three parts of a large muscle group, what we consider to be a strong muscle group. It may not always be. And with the gluteus maximus, its main job is extending the hip. It is the largest and the most superficial of the gluteal muscles. It's thick, it's fleshy, it's quadrilateral in shape, meaning it's almost like a four-sided rectangle or square. And it, of course, makes the distinction of what we refer to as the buttocks. The origin for glute max is going to be the outer slope of the posterior segment of the iliac crest. So you can kind of, whoops, I picked a bad color here for my, let's pick blue. I had red. So origin back up through here on the glute max. And it's also the surface of the ilium, so the lateral surface of the ilium, which is going to be the bone underneath here. And the side of the coccyx, the sacrotuberous ligament, which a lot of times ligament issues come into play. And as fitness professionals, we don't deal with ligaments. We send those to the PTs and the athletic trainers. The insertion is going to be the gluteal tuberosity, which merges in with the IT band right in this area. And oh, I hate this little thing right here. Let me erase that line because it doesn't let me write over what I just wrote on. So right here for the gluteal tuberosity. The nerve supply for it is going to be the inferior gluteal nerve. And of course, like we mentioned, the chief job of glute max is the extension of the thigh. But that also makes it, because of the other movements as well, which is lateral rotation of the thigh and abduction of the thigh, even though it's not a big, strong one on those last two. But because it does all of that, it's essential for helping us to maintain a nice erect posture. And that's going to be so important when we talk about the atrophy that can happen in muscles because of the injuries or the diseases that people have that require them to get these joint replacements. In addition to recuperating after they get the joint replacement. So sometimes we forget about how debilitated people are before their surgeries, and the more debilitated a person is, sometimes the longer it takes for them to rehabilitate back to where they would like to hopefully be. Your gluteus medius here in the middle is a broad, thick muscle. It's situated on the outer surface of the pelvis that you can see, and also you can kind of see it here in this picture. So while gluteus medius can be visible on the anterior side of the lateral ilium, it kind of goes deep to gluteus maximus over here. And its origin is going to be the gluteal surface of the ilium between the anterior and the posterior gluteal lines. So what we're talking about here, oops, I didn't really draw that well, from here to here. And the insertion is going to be the lateral surface of the greater trochanter of the femur. So right up here. So here is that gluteal, oops, nope, that's not the gluteal tuberosity there. Scratch that. That is the lesser trochanter. But what I was trying to point out, because I'm not a very good artist, is your gluteus maximus inserts down through here. The medius and the minimus are a little more superior. So their angle of pull is going to be a little bit different, which kind of goes into the action. So for glute medius, it's a huge abductor of the thigh. The anterior part, acting all by itself, does help to flex and internally rotate the hip. The posterior part of gluteus medius helps to extend and externally rotate the hip. So it's got a lot of action. So this portion right here will help with internal rotation, whereas this portion back here helps the glute max with external rotation and a little bit of extension. But again, its big action, its main action is hip abduction. But also too, the anterior and the posterior parts of gluteus medius work together not only to abduct the hip, but to stabilize the pelvis and the frontal plane. So that side-to-side wobbling movement, which is important when we're walking, which we'll talk about walking gait a little bit later. Now, the gluteus minimus over here, it's the smaller of the three. It's also the deeper of the three. So you've got the minimus, then sitting on top of the minimus, so to speak, you've got gluteus medius, and then gluteus maximus is the most superficial. So gluteus minimus, of course, is the smallest. It is originating on the gluteal surface of ilium between the anterior and inferior gluteal line, but you can see that it's a little bit, the attachment is below or inferior to the gluteus medius, even though it's in about the same area. And the anterior surface of the greater trochanter is where it's going to insert. And you've got, again, another powerful abductor with a little bit of lateral rotation of the hip. So like we mentioned, the gluteus medius and the minimus work together to abduct the thigh, especially when the limb is extended, when the hip is extended. They're primarily called into action when supporting the body on one limb. And that can also be assigned the name escapes me, but Trendelenburg sign, where you shift your weight to one leg and lift the opposite leg. And if your hip drops down, then that may be a sign of gluteal weakness, especially in medius and minimus. So you may have heard of that. And when the hip is flexed, the gluteus medius and minimus internally rotate the thigh. And with the hip extended, the gluteus medius and minimus externally rotate the thigh. So hip position is going to be very important when we're talking about exercises to make sure that you are truly hitting the muscle in the way that you need to work it and activate it. And then, of course, we've got tensor fascia lati, which is a slide here. And the TFL, it's kind of a tiny muscle. It merges in with the IT band, as you can see in this picture. So here is your TFL right here. And it works with gluteus maximus and its function and its structure, and it kind of merges in with the IT band, which the gluteus maximus also does a little bit, so to speak. And it is going to originate on the anterior surface of the outer lip, or the outer portion of the iliac crest, kind of sort of up towards the ASIS, but not quite, the anterior superior iliac spine. And its insertion is going to be that IT band about 3 to 5 centimeters below the level of the greater trochanter. So levers is important. The longer the lever, the more pull you're going to have. So the further away it inserts from its origin, the more pull you're going to have. And so this one's got some pretty good pull just because it is merging in with the IT band. So it, of course, is going to abduct the thigh. It medially rotates the thigh, and it is a weak extensor of the knee joints because the quads are the biggie on that, but it does assist a little bit. The TFL, it continues as far as its direction, oblique direction of its fibers to help stabilize the hip when in extension. So again, that's going to be very important for core and hip and pelvis stability. It's, the fascia itself is a fibrous sheath. It's not really a muscle. It's a thick fibrous sheath that encircles the thigh and kind of like a sock going on your foot, so to speak, and it binds with the muscles. So on the lateral surface, it combines with the tendons of the glute max and the TFL to form that iliotibial tract or iliotibial band, which extends from the iliac crest down to that lateral condyle of the tibia, which you can see all this white all the way down to this area. So when standing in an erect posture, acting from below, it's going to help to steady the pelvis on the head of the femur by means of the IT band tract, because it's going to help steady the condyles of the femur on the tibia. So it assists the glute max in supporting the knee in a position of extension. Excuse me. So your basic functional movement of the TFL is basically walking, helping us with stability with walking. So that's why we don't want to forget TFL. So if your client skis, of course that might be why they are getting a hip or a knee replacement, or was a hurdler at some point in time, riding horses, things like that, sometimes problems arise with this muscle because of the imbalance with the adductors So all of that can lead to some problems. And to add to the TFL, this picture on the right, when the hips are flexed, the glute medius and minimus are inactive. So back in the day, I've been in this field a long time, but back in the day, this was the machine, the hip abduction and adduction, to help tone the thighs and this, that, and the other thing. And it doesn't really because it's not getting medius and minimus. So just an FYI on that. Some other things to consider also is after 30 degrees of hip flexion, the glute medius and minimus are not able to abduct the hips, which kind of goes back to that picture that we were talking about, the seated hip abduction and adduction machine. And what's really working is the TFL, the tensor fascia lati muscle. So this is why it's important to get a lot of different positions and variations in your exercises as your client is ready for them. You know, getting up and down off the floor may be a challenge for them if you have a treatment table. And treatment tables are padded tables that may be about 2.5, 3 feet off the ground, and it makes it easier for clients to get on and off the table rather than the floor to do some of these exercises. If you don't, then you will want to consider modifying these so that they can do them in a seated position from a chair, which we'll get into in a little bit. But using body weight, using stability balls, such as this picture down here, she is actually doing a really good job on this one, pushing the leg back or extending the hip a little bit in isometric contraction to keep the ball up against the wall while she is abducting the hip. So we're getting a good isometric contraction on glute maximus and getting a good workout on glute medius and minimus. So, you know, activate your different muscles in different positions, but make sure you're activating the muscle you think you're activating, which may involve getting that review of anatomy a little bit. So the hip external rotators, these are sometimes called the deep six hip rotators. The muscles are going to be the obturator internus, obturator externus, gemellus superior, gemellus inferior, quadratus femoris, not to be confused with quadratus lumborum, which is a lower back muscle, but quadratus femoris, and then the picky little piriformis muscle. We focus on the piriformis muscle mainly because the sciatic nerve either runs through that muscle or just inferior to it, which means a lot of times people have sciatica. They think it's their disc in their lumbar area, and that might be that if the doctor does an x-ray and everything's looking good, normal, the back is fine, it could be the piriformis muscle. When the piriformis muscle is activated, causing external rotation, it can compress on that sciatic nerve. So if you have somebody who, I learned this term, it may be a Southern term. If there are any people listening to this from other parts of the country, you're going to go, what? But I had never heard this term before, and I'm a born and bred Southerner. It's called slew-footed, and Georgia State University is in downtown Atlanta, and our big low-income-oriented type hospital is there. I mean, anybody goes there, but it's really where, you know, we have homelessness just like other big major cities, and a lot of the homeless individuals go to Grady to get their care, and they're not charged, obviously. And so we see all kinds of things, all kinds of walking gaits and things, you know, just walking around campus that have nothing to do with our students. It's people going back and forth to the hospital. And when you see people who has one hip that's so externally rotated, it almost looks like they're swinging their foot forward, but it's the medial side of the foot that is coming forward instead of the toes. That is called slew foot, which I did not know. I just called it external hip rotation. And that could create a lot of sciatic nerve compression because the piriformis muscle is tight because of that external hip rotation. So what I'm really kind of trying to say in about 5,000 words or more is look at your client's posture, especially watching them when they don't realize that you're watching them, because when they realize it, they start correcting everything, and see if they tend to walk with one or both feet more than about 5 degrees externally rotated, and they have sciatic issues. They've had the sciatic issues checked. It's not coming from the spine or the disc. You may be looking at an issue that you as a fitness professional, we as fitness professionals might be able to help correct by just doing some simple stretches. So we don't want to forget about the deep six hip external rotators, and especially that piriformis, because I know we're talking about hip and knee replacements. Well, people compensate their position to help alleviate pain, and sometimes that compensation becomes their permanent walking gait or their permanent movement function and or movement pattern, and it's not a good one. So it's leading to other problems. And same thing after rehab. Or after the surgery, and making sure that they get out of those habits of those bad movement pattern type compensations, and this can be one of them. So when we're looking at the piriformis is an interesting muscle. It internally rotates when the hip is flexed. It externally rotates when the hip and the knee are straight. So the stretch, the seated piriformis stretch that's shown in the slide right here is a great stretch. You can do it on the floor, lying on your back, pulling the opposite knee, this leg, the knee towards you, to help stretch the piriformis. And because you're flexing the hip, if you're keeping your back flat on the floor, you're not rounding the back and lifting the glutes off the floor. It's also a nice hip extension stretch. It's getting the hip extensor, so gluteus maximus. And that's why a lot of people say, well, I'm feeling it right here in my glutes. Well, they're getting glute max, and they're also getting piriformis. So let's move forward here. And some exercises that can help work these muscles in their external rotation. Your biggie's going to be your clamshells. You can start with your client on their back. Makes it a little bit easier than on their side, because on the side you're working against gravity. You can use a band. You cannot use the band. It just depends on where your client is strength-wise. And basically you're just going to lie on your back or on your side. If you're on your side, you want to make sure that the feet and the hips are stacked. And whether you're on your back or your side, the knees are bent at 90 degrees. And you're going to draw the knees toward your body until your feet are in line with your glutes, especially if you're on your side. And if you are on your side, you're going to place your left hand on your left hip. So if you're on your right side, just like this guy in the picture on the right, and you got to make sure not to tilt backwards. This is strictly hitting the hips. And the tendency sometimes is people think if some is good, more is better. And they start trying to externally rotate that hip to the point that now they're rolling back. And that's not stabilizing what needs to stabilize, and they may end up having back problems later on. So we don't want that. So form is key. So that means you got to keep your abs engaged, keep your feet together, and then you're going to raise the left knee. Actually, in this picture, he's raising his right knee, so I'll say right knee, as far as you can without rotating your hip or lifting your left knee off the floor. You can have your client hold it for a second, squeeze the glutes at the top of the move. That may be something, especially if they've had hip surgery, it may be something that they need to progress to. And increase that length of time on the hold to maybe 5 seconds before slowly lowering the right knee to the starting position. We want them to slowly lower it. As you guys know, working with bands, it's that eccentric contraction that's really going to help them to strengthen the muscles. So we don't want them to just drop the knees back together. We want them to control that on the down phase. Start them off with however many repetitions that they can do correctly. And once they start to fatigue, then stop them there, because fatigue is going to lead to poor form. So again, talking about hips and knee replacement, that you just got to see where your client is. And chances are they have done this exercise and physical therapy as a part of their rehab, and we as the fitness professionals are taking them to that next step. So sadly, I think sometimes people think that once physical therapy is done, they're done with their exercises, and the answer to that is no, you need to keep doing your exercises, and that's where exercise physiologists and fitness professionals, certified fitness professionals, can step in to help the client continue to get stronger and get better. So if you do want to make it harder on the clamshells, of course, you can add the band around both sides, and the resistance of the band depends on what color band you're using. So you can progress it from the easiest to the hardest. The muscles that you're targeting, like we mentioned, are going to be gluteus medius and gluteus minimus. And like we mentioned, we just cannot overstate how important strong glutes are, especially the medius and the minimus. And we forget about those. A lot of times people think that by doing bridges and hip extensions and things like that, that they're getting all of their glutes, and they're really not getting medius and minimus with those exercises, so they get weak and they start causing problems. So your glute activation is really important, and people don't realize how weak those muscles are. And the weaker those muscles are, the more problems they're going to have performing not just other exercises, but other daily activities, such as a squat to get up out of a chair or off the toilet, or to sit down on the toilet or in a chair. And a lot of people with their weak glutes tend to use more the quads and their back. They're flexing so far forward with their trunk. And this is going to help correct a lot of activities of daily living, which is really going to help them with getting well, especially after their joint replacement. So very, very important on those muscles and strengthening those muscles. And looking at the knee anatomy, kind of shifting gears here a little bit inferior down the body, usually people really know the knee anatomy. I tend to find with my students, they're like, hip, shoulders, no, not really. Knee, oh yeah, I got the knee. But let's review it anyway. So we have the cartilage of the knee. We have articular cartilage, which is more specifically that hyaline cartilage. It goes around and protects the ends of long bones. That was a bad drawing. I can't draw anyway, so to do it with a computer mouse is even more interesting. So. And then, of course, we have the fibroelastic cartilage that makes up the meniscus. A lot of times people refer to the meniscus as cartilage, and that's actually what it's made of. The name for the structure is meniscus, just a little FYI, if you play any games or anything that might help you out with that question one day. And then, of course, you got your ligaments. You got your anterior cruciate ligaments running from the lateral side of the femur to the medial side of the tibia into and connecting with that medial meniscus, which also connects with that medial collateral ligament. So if you've ever heard of the terrible triad or the unhappy triad, it's when a person tears the ACL, the medial meniscus, and the medial collateral ligament, because they're all really connected. Then you've got your posterior cruciate ligament, goes from the medial side of the femur to the lateral condyle of the tibia, and then you've got your lateral meniscus here, and you can see with the lateral collateral ligament, it doesn't attach right here to the meniscus, so you can have isolated tears in there. And a lot of times what happens with arthritis is the hyaline cartilage starts to wear down, and the meniscus starts to wear down because now you're getting more bone on bone. And that's very painful. It's like having a broken tooth in your mouth, a bone like that has the nerves exposed. And then you've got the synovium, the lining of the joint space to help form the capsule. The synovium is just a layer of tissue that helps define what that joint space is. And inside the capsule is the synovial fluid, which I always explain in a way that if you know about cars, it's like having oil in your car, in your engine. It helps to lubricate it. You need to warm your car up sometimes to get that oil circulating to help lubricate all the parts of the engine so it runs smoothly. Same thing with the knee. This is one of the reasons why warm-ups for exercise are important, is to get the synovial fluid moving to circulate and lubricate those joints. We also have bursa sacs. We have about 16 bursa sacs in the knee. And basically, these are just structures that kind of end up between two moving parts, and more commonly it may be between a muscle and the bone, or a tendon and the bone, so that you don't have direct rubbing over a muscle and the bone. It helps to kind of protect it. So it allows for smooth movements between those structures. And we have hundreds of bursa sacs throughout the body, so it may seem surprising that we have so many in the knee, but it really isn't. The biggie is the bursa sac that's in front of the patella, the prepatellar bursa. If you fall and land directly on your knee, that can swell. And you hear sometimes people getting excess fluid off their knee. Might be the bursa sac that they're working on to try to get that to reduce swelling, or what's otherwise called as bursitis. And if you get bursitis, it doesn't let the structures move smoothly, and compensation starts to occur, and it starts to cause problems. And when you start to change your mechanics, you start to change wear and tear on those bones, and that can lead to needing hip replacement or knee replacement later on when it gets bad enough. So the knee itself, it of course is a hinge joint, and it allows us to flex and extend the knee, but we also have something called the screw home mechanism, which helps the knee to slightly, very slightly, externally rotate the tibia on the femur when we fully extend the knee. And it's very, very slight, but that's why we call the knee a modified hinge joint. For the most part, it is strictly a hinge joint with flexion and extension, but because of that slight rotation that occurs when we extend the knee, it becomes a modified hinge joint. And too much of that rotation, especially under pressure, such as if your foot's planted and your femur rotates on the knee, that's when you start to get your ligament tears and your cartilage tears. And if the tears are bad enough, cartilage doesn't have a whole lot of blood flow, so they don't heal very well or very quickly, and that can sometimes lead to bone rubbing on bone, and then you get the osteoarthritis. So, looking at quads and hamstrings, most people are pretty darn comfortable with all of this stuff, but basically you've got your four quad muscles: rectus femoris, vastus intermedius, vastus lateralis, vastus medialis. And all four of those quad muscles insert on the tibial tuberosity, which looks like in this picture is about right here. It's that bump just below your knee on the anterior side. And they connect by way of the quadriceps tendon, which eventually becomes a patellar ligament. Now, to differentiate with that, usually layman terms, people call this whole thing the patellar tendon, and technically that is not true. Tendons attach muscle to bone. So your patellar tendon runs from about here until you get to the patella. That's a tendon. Ligaments attach bone to bone, and technically that's going to be the part from the patella down to the tibial tuberosity, because that's bone to bone. So something to keep in mind, if you read that and you're like, wait, I haven't heard of a patellar ligament, technically there is one, and that's why. So your quads, rectus femoris originates on the anterior inferior iliac spine, and from the superior edge of the acetabulum. And it is a biarticular muscle, meaning it functions for two joints. It's the hip flexor, it's one of the hip flexors, and a knee extensor. So all four quad muscles extend the knee, but the rectus femoris has a second action, which is hip flexion. The vastus lateralis is going to originate on the lateral lip of the linea aspera. I always kind of sing that one with my students because it's fun. And the linea aspera is the ridge on the posterior side of the femur. So it kind of wraps around from the posterior side of the femur around to the front. So the vastus lateralis originates on the lateral lip of the linea aspera. Guess where the vastus medialis originates? On the medial lip of the linea aspera. And then we've got the vastus intermedius. This is the deepest of the four muscles. You can't see it unless you move or cut through the rectus femoris. And it is going to originate from the front lateral surfaces of the body of the femur, sitting directly underneath the rectus femoris muscle in the lower part of the lateral intramuscular septum. And it's the hardest one to stretch. It's very difficult to stretch, and it's very difficult to really work as far as getting it lengthened manually, foam rolling, all of that, just because it's such a deep muscle. So that is something else to kind of remind ourselves of. And then over on the right side, we got the hammies, the hamstrings. You got your biceps femoris, and what I love about the hamstrings is you can really feel these on yourself. I always tell my students, if you forget which side of the tibia the two semis insert, feel it on yourself. So if you're sitting right now and your knee is flexed, if you're just above the, kind of on the femur part of the posterior side of your leg, you can feel a big ropey tendon on the lateral side, and that's going to be your biceps femoris. On the medial side, on the posterior side of your leg, you can feel, you have to kind of move around a little bit, but you can feel the two tendons. One's a little bit more prominent, which is the semitendinosus, but both of them are on that medial side, semimembranosus and semitendinosus. And they're going to originate from the ischial tuberosity. And of course, the semitendinosus is a part of what we call the pes anserine, which also includes the sartorius and the gracilis. And they just all insert basically and very close in the same spot. And then, of course, we don't want to forget the gastrocnemius. You see someone who's had any kind of knee surgery, you see that the gastroc is very atrophied. Gastrocnemius is a very weak knee flexor, but it does help flex the knee with the hamstrings. And I didn't mention the hamstring action. All three hamstrings extend the hip, but it's not the primary movement of the hamstrings because your big hip extender is going to be that glute max. Hamstring's big movement is knee flexion, and that is missed a lot of times and as far as exercise goes, and creates a lot of imbalances. People think, oh, well, I'm doing hip extension, so I don't need to do another exercise for the hamstrings, so I'm getting it. And then you're not really. It's not the primary mover. And so it's very important, especially when you're working in a post-rehabilitative type situation, to make sure that you are working the muscles in their primary movement, not in their synergistic or assisting movement. Because that will help get it stronger. So we got to do some knee flexion exercises against resistance to get the primary movement of the hamstrings. And that means gastrocnemius is also going to be helping, but of course the big movement for gastrocnemius is when the knee is straight, it plantar flexes the foot or lifting up on the toes. Your soleus, which is going to be deeper to the gastrocnemius, its primary mover is it doesn't do anything at the knee, doesn't cross the knee joint. I always tell students that when a muscle crosses a joint, it has to move the joint. So if it does not cross the joint, it doesn't move that joint. And soleus does not cross the knee joint. It starts about 2/3 of the way down on the lower leg on the posterior side, and its sole action is plantar flexion. So we work soleus when the knee's bent. We work gastrocnemius when the knee is straight and plantar flexing the foot. Okay, that's a lot of anatomy there. Sorry about that. But it is important to understand the anatomy before you start getting into the exercises. And we know that not everybody gets a whole lot of anatomy, depending on where your education and your field focus is. So very important. So when the knee and the hip are flexed, and the knee is about 45 degrees, so just this gentleman over here in this picture, you have about 45 degrees of external rotation of the hip and about 25 degrees of internal rotation. So we're talking about the external rotating out this way. That's going to be external hip rotation, even though we're kind of looking at the knee, and then the internal rotation. So we know internal rotation is limited at the hip. So we have to keep that in mind and try not to force people into positions that they anatomically cannot do anyway. When the hip and the knee are straight, there's about 8 degrees or 8 to 10 degrees of internal and external rotation. So again, looking at the hip. So your practical explanation, remember I was saying earlier that when people are hurting, when people have an injury, we all tend to compensate, which means we're changing our movements and our movement patterns. And if the pain is chronic, that movement pattern becomes their quote unquote normal. And that movement pattern may cause more problems because of the compensation. So as weird as it sounds, sometimes we need to reteach people how to walk properly. I remember walking behind a woman who had had knee replacement. And because she was so used, she finished physical therapy and was coming to me for post-rehabilitation, and she was so used to wobbling or waddling, where she never would bend her knee. She kind of swung her left leg forward by shifting her weight to the right and vice versa, instead of keeping the feet moving forward and flexing and extending the knee like we normally would. But it had become such a habit for her because, understandably, doctors say, we don't want to do the knee replacement too soon. We don't know how it's damage or whatever's going on in the hip or the knee is going to progress, and it may not. But we need to get it to the point where nothing else is working, and it's time to do that knee replacement. Well, the challenge is, in the meantime, people are modifying their walking and their movement, and it becomes second nature for them. And it's just, one of those hurdles and hiccups that we have to kind of to work with as much as possible, because having them walk normally maybe hurts and they don't want to do it. So we may be dealing with breaking a movement pattern the person has had for years, decades even. So getting back to the basics, when they come to us for that post-rehabilitation, and again, they have been working on it in PT, but making sure they continue to walk correctly. So 5,000 words or more, here we go. So weight transfers from heel to ball of the foot, then to the toes. So ankle range of motion is very important. If they have limited ankle range of motion, remember the ankles are the foundation for our base. And if there is a problem going on at the ankles, it's going to translate further up the body. So sometimes what has to be worked on first is ankle range of motion so that they can roll their heel to toe. So remember, I was just saying on that previous slide with the knee, with the anatomy, we don't want to forget about the gastrocnemius and the soleus when it comes to getting it flexible again and strong, and that anterior tibialis as well, because that helps to dorsiflex the foot. So when the ball of the foot contacts the floor, the opposite foot begins to lift. Then you swing the foot. It lands in front of the stance foot. At an average stride is about 2 to 3 feet. We don't want people taking these little teeny tiny steps, and sometimes they do that because they're concerned about balance issues, and that may be a sign that you also need to work on the balance. The pelvis is squared. They don't need to strut their stuff. We want to keep the pelvis squared and the spine in neutral. So we need to give them head to toe cues. We want to make sure that they're not flexing their trunk forward or flexing the hips forward. We want to keep them in a good neutral so that when they push off with the back foot, they feel that in the glutes. When they're walking up the hill or walking up steps, if they lean too far forward with their trunk, their glutes are not going to get used. So we want to get their proper walking on flat surfaces, and then we progress them to walking up the hill or walking up steps and making sure that they're staying fairly upright with their trunk so that they keep those glutes working and keep those glutes strong. So just to kind of go over a little bit about the muscles, and I've already kind of talked about this a little bit. So your heel strike, you're looking at hip flexors and quads to swing the leg forward. So hip flexors to flex the hip, quadriceps to start extending the knee to get ready for the heel strike. Tibialis anterior is going to dorsiflex the foot so that you do heel strike. Then your weight bearing or the mid stance is going to be gluteus medius and minimus to help stabilize the pelvis. Otherwise, you're sashaying, and we don't want to sashay. And then on the push-off part, gluteus max and the hamstrings work together to pull the leg back, that hip extension, mainly glutes, and then gastrocnemius and soleus plantar flex the ankle for the push-off. So again, we got to look from the base up when we're looking at our exercises to help our client get better. Start with those ankles. So shifting gears a little bit, why do people need some joint replacements? Well, all kinds of things, and you guys I'm sure are familiar with it. The biggie being osteoarthritis, which could be from a trauma or a fall and it just got worse, or repetitive stress that just got worse, or they may have rheumatoid arthritis, which is a systemic arthritis. It's and it is lumped in with arthritis because it does eventually damage joints. The rheumatoid arthritis, these are the people that may have joint replacements kind of young, because this is also known as juvenile arthritis. But it is a systemic thing, so sometimes the joint replacement helps, but I've actually seen, and I'm sure any PTs and OTs that are listening right now, but I was just fascinated by this. This was a long time ago, but we had a young girl, about 22, 23, who ended up having metacarpal joint replacement in her hand. So the metacarpal and the proximal phalanges in each hand had just worn down, and she had joint replacement there. And I thought, wow, you know, that's cool. As an exercise physiologist, we focus on knees and hips and shoulders, you know, and here you had it in your hands. I never would have thought of that. I digress. Sorry about that. But then, of course, trauma, you know, car accidents, ski accidents, maybe they had healthy joints before, but the trauma or the fall or the injury led to joint damage that they, you know, had to go in and replace the joint. Bone tumors are rare, but they can lead to needing a joint replacement. That can happen. And sometimes the bone tumors are benign, but that can cause damage to a joint. And then obesity, because of the repetitive stress and the excess weight and trauma to the joint. So your general training goals, and again, we're talking post-rehabilitation, is identify the risk factors. I just saw that typo there in factors. Manage asymmetry. Again, those compensations. Do they favor one side than the other? Do they tend to shift their weight to one side when they stand because before the knee replacement or the hip replacement, it took the pain and pressure off that joint? We need to fix that, and that's the toughie. I've seen all kinds of people, myself included, that the habit is to shift their weight to one side, and that's really not a good thing to do. So that's a habit that many of us may need to break. We need to improve mobility and strength, improve static and dynamic balance, and understand proper progression. And here's the thing with proper progression. It's not going to be the same for everybody. So you really have to individualize with your client, which means that last bullet point, you're always reevaluating your client. And again, part of that evaluation or reevaluation is watching your client move and do whatever activities they do at your gym or your facility, and just watch them when they don't realize they're being watched. And that will provide you with so much information to help you out, as far as helping you to help your client. So some negative correlations, issues that can make rehab more challenging is living alone, because again, they don't have somebody there to remind them, hey, stand up straight, hey, watch how you're sitting, hey, make sure you're doing your exercises. Increased body mass index, which, correlates with obesity. And the challenge with that is you've got somebody whose joints hurt, and it does make it hard for them to exercise to help get rid of that excess weight. So this is where pool exercises can come in very handy. But if they don't have access, or it's hard for them to get there because they can't drive for a while after their surgery and they don't have anybody to drive them there, that's going to be a limitation. We talked a little bit about number 3 earlier, their pre-op condition. Like we said, people have these problems, sometimes these chronic issues for decades before they end up getting their joint replacement for lots of good reasons, but the challenge is that their muscles have atrophied, their compensations have led to other problems. A common compensation that has been seen is you have the person who shifts their weight, let's say, to their left leg when they're standing because their right knee hurts. And it's not uncommon to see that they need a left hip replacement later because so much stress has been placed on that left hip because of the weight shift. Pre-op conditions is where a lot of orthopedics and hospitals and PT clinics are getting into pre-rehab to help get the client as strong as possible before the surgery. So that is something to help offset that one. Older ages, and we're not saying all older adults are the same. I try to explain that to my students, I think mainly because I'm getting up there and I don't want them to think that I'm frail. But you have some very active older adults. We have some very frail and sedentary older adults as well. So as the person ages, sometimes the challenge is keeping them moving regardless of their health. And if they have a joint problem on top of that, it just makes it even harder for them to move. And the challenge is getting your clients to realize, hey, when you retire from your job, not from your life. So keeping them moving, which again helps out with number 3 and number 2. How long they wait before surgery, I think we already kind of hit that one. And number 6, we kind of hit the lack of rehabilitation before the surgery. So that is something to help guide your clients, because as fitness professionals, they may be coming to us saying, well, I got to get this surgery done. I'm really nervous about it. And we might be able to say to the client, well, hey, have you talked to your doctor about getting some rehabilitation done? Get those muscles as strong as possible before the surgery. It helps with the post-rehabilitation afterwards. So that's where we can come in before the surgery as a fitness professionals, is to encourage the person to talk to their doctor about these options. And then lack of physical therapy afterwards. Granted, people don't get kicked out of physical therapy, but I did know someone who was not going to his appointments and was not doing what he was supposed to do after having both of his knees done at the same time, and I'm sure there was a very good reason that they decided to do that. But if, again, they didn't get kicked out of physical therapy, but the PTs really kind of got tired of him taking a time slot and then not showing for it because it was taking a time slot from somebody else. And unfortunately, this gentleman was back to walking, in his pre-surgical waddle. And his knees hurt, and this, that, and the other thing. And it didn't help him. His surgery didn't work for him because he didn't work after the surgery, if that makes sense. So physical therapy is not meant to feel great and wonderful. It's meant to get people over that hump after the surgery so that they don't have scar tissue finding them later. It hurts, but it's going to hurt less and less the more they go. And if they don't go, then they've really wasted their time getting that surgery done, in my personal humble opinion. So as fitness professionals, your client may be getting physical therapy for their joint replacement, but they're still maybe coming to your facility for other exercise. And that's important if they have other comorbidities such as diabetes or heart conditions, that kind of thing. It's important for them to keep up with their exercise and their cardio, which is where the pool might come in handy. But that's also where we as fitness professionals need to remind them. You know, if they say, I don't want to go back to PT, it hurts. It's like, you know, it's supposed to hurt, but it's going to start hurting less and less the more you go. And you need to go, you know, because it's going to get worse and be a permanent problem for you, blah, blah, blah. So that would be our role at that point in time, which kind of hits on this next slide as well. In addition, now granted the study was done in 2009 and it's 11 years old, but it's pretty much saying what we all still know nowadays. But what the study found was 60 days after knee replacement, extensor strength was only equal to pre-surgical levels. So they're still deficient. So physical therapy is just kind of getting them back up to being functional. Their post-rehabilitation is to help get them back into their life, if that makes sense. So the study also found that strength gains beyond the pre-surgical levels occurred after 60 days of training, but most physical therapy stops at 60 days. So again, post-rehabilitation is so important. They've got to continue. And then fitness training is vital to increase the strength and the function of the involved knee. But here's the thing, you don't just want to throw them back into the workout program that everybody else has been doing. You need to go through some of these exercises that we're going to go through, talk to the physical therapist that they worked with, find out, get permission from the client because of confidentiality, to find out what were they doing in physical therapy the last week or two before they were released, so that you, the fitness professional, can pick up from there and continue to help them improve. So let's talk about some of these joint replacements and what's going on. So let's look at some numbers here. Success rate after 10 years of having a hip replacement is really high, 90 to 95%. At 20 years, it's 80 to 85%. So it's man-made. It's a man-made joint, so it's not like, you know, our original joint. So it's going to decline in function a little bit, but again, that's pretty darn good for a success rate 20 years later. So sometimes you may have clients who are getting hip replacements at younger ages because of this. You don't want to get it too young because after 20 years, you're still going to have some decline. So, you know, that's why sometimes doctors will wait until it's really necessary to do it so they can get the maximal benefit out of that new joint. 50% of hip replacements are people under the age of 65. Now, why that is, who knows? You know, people do more daring things in their youth than they did maybe 20 years ago. You know, you got rock climbing, you've got skiing, you've got all kinds of sports and activities that can lead to traumatic injuries. We have to look at the history of our equipment. I mean, gosh, I'm in my 50s, and when I was in my teens, we didn't have the nice running shoes that we have nowadays. The first woman to run the Boston Marathon, who was an illegal female runner at the time because women weren't supposed to do it, she didn't have good shoes. The New York Marathon, I think it was another woman, and she ran in nursing shoes. This is in the 70s. So the equipment that we have and the knowledge that we have gained about biomechanics and more in-depth anatomy and how the body works has changed equipment and changed how we do things. But the people who didn't get those changes at a younger age are kind of paying the price for it at younger ages by needing to get joint replacement. So it's a combination of a lot of different things. 34%, for the same reasons we were just talking about, are between the ages of 45 and 65. That's a chunk. And then 18 out of 100 replacements require revisions. Now, that is a scary statistic if you're one of the 18, but that actually isn't bad. And the question is, what did those 18 people out of 100 do or not do where they did have to get another replacement of that joint, or was it just a bad joint that they got? Because again, this is man-made, it's not going to be perfect. So that 18 out of 100, 18% can be a scary number, but really if you think about it, it's a low number. You know, so don't let that deter your client from getting the surgery. So your surgical options, there are three main ways that doctors do hip replacement. And it depends on the doctor, it depends on their skill, it depends on the patient, their age, the diagnosis, what the condition is, where the problems are in that hip joint, what is their activity and lifestyle like, and unfortunately, Medicare reimbursement or other health insurance reimbursements may dictate that a little bit, but doctors can fight for that a lot of times if they feel that another approach might be better. So let's look at these different approaches. The posterior approach is also known as the quote-unquote traditional approach. It is more commonly used, and it's one of the earlier techniques, so your surgeons are pretty darn proficient at it because they've probably been doing it for a long time. And it basically cuts through the most musculature, which has three main precautions to movement after the surgery because of the muscles that they're cutting through. So basically a 10 to 12 inch incision is made on the side of the hip, and the glute max, the medius, the minimus are either cut or moved out of the way. And if they can move it out of the way, that's ideal, but they have to be careful of all the nerves and everything in there as well, and access to the joint based on how far they can move it out of the way. Piriformis and some of the small external hip rotators, those deep six hip rotators we talked about, are also cut. The main focus after surgery is range of motion and slowly activating these muscles to return to normal through strength and stability. The muscles are split or detached from the hip, allowing the hip to be dislocated and fully viewed by the surgeon. The damaged femoral head is removed, and it's going to be replaced with a metal stem, usually titanium or some type of material like that. It's not going to rust or anything. And you've got a metal stem that's placed in the hollow center of the femur, so they hammer that in. And then a metal or ceramic ball is placed on the upper part of the stem to create the ball of the ball and socket joint. The damaged cartilage surface of the socket, which is in that acetabulum, that's the other part of the hip joint. You got the ball that fits into the socket. The acetabulum is that quote-unquote socket. And that damaged cartilage is going to be removed and replaced with a metal socket. And then screws or cement are sometimes used to kind of help hold the socket in place. And that cement needs to set, so to speak. And that's why one of the reasons why range of motion has got to be limited for a little while. So then the plastic or ceramic or the metal spacer is inserted between the new ball and the socket to allow for a nice smooth gliding surface. So this one is minimally invasive. Total hip replacement can be informed. Sometimes 2 incisions are made, sometimes 1 incision is made. Of course, the fewer and smaller incisions, the better, because it's less cutting and less healing. So it just depends on the surgeon, the technique, and the other issues that we talked about that may be going on with the joint itself. The hospital stay is usually anywhere between 1 to 4 days, depending on how the surgery went and other health issues the client may have. So, for example, if they're on blood thinners, they may stay in the hospital overnight to make sure that they can get them back on their blood thinners because they have to go off of them or else they'll bleed out during the surgery. And, make sure that there's no clotting issues, and because any major surgery can increase the risk of clots. So they're going to want to make sure that everything's good, everything's stabilized before sending somebody home. So 1 to 4 days, depending on multiple situations. Now, the anterior approach, the main difference between the anterior hip replacement and the posterior or traditional hip replacement is, of course, the location of the surgical incision. The location of the incision is going to determine which muscles are cut. So with the anterior hip replacement, you're looking more at quads, hip flexors, those muscles that are going to be cut or moved as much as possible, hopefully without having to be cut. Compared to the traditional or the posterior hip replacement, the anterior hip replacement typically involves less damage to the muscles. And on the flip side, it's also more challenging for the surgeon. So again, it goes back to surgical comfort also. Why some surgeons prefer this one is in recent years, the preference has increased for the anterior approach because there's less post-operative pain for the client or the patient because there's not as much damage as the posterior. You're not cutting into as many muscles, or maybe not at all. And that can also lead to an easier and faster recovery during the initial 2 to 6 weeks after the surgery. So whether or not the anterior hip replacement has better long-term results compared to other surgical approaches is still out there under research because this is a fairly new surgical technique. So the lasting effects and improvements is still out there, but so far things are looking good, bottom line. So because it's less invasive, it involves little to no muscle cutting. So, what really matters is the amount of damage that's done to the muscles and the other soft tissues during surgery. So the less muscle cutting you do, the faster and less painful recovery. So this one may also be considered if your person has or needs an active lifestyle because of other health issues that may be going on, and or they live by themselves and they need to get up and around a little bit faster. This might be one of several reasons as to why a doctor chooses this approach. And well, I kind of got ahead on here, but this is someone post-op. So you can see how tiny the incisions are in order to do what they need to do. Now, the actual structure of the hip joint itself is the same. What we're talking about with the anterior, posterior approaches is how they get to the joint to replace it. Now, another option, depending on what's going on with the client, might be hip resurfacing. This doesn't completely replace the ball of the hip with the metal or ceramic ball. Instead, the bone is kind of reshaped and then capped with the metal prosthesis. I always kind of think of like a crown on a tooth. The tooth is still there. They just kind of put, drill it down and put a cap on top of the tooth. This is kind of the same thing in my head, so to speak. So, and the hip resurfacing, like we said, the femoral head's not removed, but it's trimmed down, it's capped with the smooth metal covering. The damaged bone and the cartilage within the socket's removed and replaced with the metal shell, just as in the traditional hip replacement. So there are going to be some advantages. There's also going to be some disadvantages, but advantages include that it's a little bit easier to revise it if necessary because the components or the implants used in a hip replacement, hip resurfacing are man-made. They do wear out or loosen over time. And if they had a hip resurfacing, it's a little bit easier to fix that than to go in and put a whole new hip joint in if they had the total hip replacement done. So if the implant fails, they're going to need another surgery, but again, the recovery with hip resurfacing is a little bit faster because it's not as invasive. There's a decrease of risk hip dislocation. Another reason why we got to be careful with our clients, and our clients need to be careful after the surgery itself. But with the hip resurfacing, there's going to be less chance of that hip dislocation to begin with. So in the hip resurfacing, the size of the ball is larger than the traditional hip replacement is, and it's closer to the size of the natural ball of your hip. And because of that, it makes it a little harder to dislocate. Normal walking patterns. Some studies have shown that walking patterns are more natural following a hip resurfacing compared to traditional hip replacement. These differences may be subtle, but it may be enough that it makes a difference for the client. Now, there are some disadvantages to the hip resurfacing as opposed to a total hip replacement. One of them is femoral neck fracture. A small percentage of hip resurfacing patients may have a fracture in the femur, and if that happens, then they may have to go back and get a total hip replacement done. Metal ion risk. In the hip resurfacing, the metal ball moves within a metal socket, and over time, the friction between the two surfaces might lead to the release of tiny metal molecules called ions. And these ions can cause a reaction in the hip bone and the soft tissue, which can lead to pain and swelling. It's minimal. The risk of that is very low, but again, it's one of those risks when the patient's talking with their doctor about their different options. So it's something to think about. The surgical procedure for the hip resurfacing is about an hour and a half to 3 hours. And the surgeon still, of course, has to make an incision into the thigh in order to reach the hip. The femoral head's dislocated, just like with the total hip replacement, but then the head is trimmed, and the metal cap is cemented over the prepared femoral head. And the cartilage that lines the socket is removed, and they use special tools to correct that, and metal cup is then pushed into the socket, held in place by the friction between the bone and the metal. And then once the cup is in place, the femoral head is relocated back into the socket, the incision is closed up, and they're done. Their hospital stay may be a day. Just as with any surgery, they're also making sure that there's no infection, there's no blood clot, there's no nerve damage. It can happen, but it rarely happens. So they want to make sure there's no nerve or blood vessel damage or a fracture in the femoral neck. And then, of course, the risk of anesthesia, they want to make sure that everything's good. So most patients go home about the same time frame, 1 to 4 days after the surgery, depending on their health and other factors we've already talked about. So this may be an option for some clients, and it's something to find out from their doctor. So the post-surgical precautions, I actually kind of got a little ahead on that, but pain, of course, is the most compelling indicator. After surgery, we already talked about the risk of hip dislocation, especially if that posterior approach was used. Again, it's less of a risk if they had the hip resurfacing. And if it happens, it is a medical emergency, call 911. So the posterior approach may have more limitations in a hip flexion greater than 90 degrees, internal rotation past neutral, and adduction past the midline. So those are movements they're going to need to avoid, sometimes up to a year. You can work through those ranges of motion, and again, by the time they come to us as fitness professionals, they know what their limitations are, and that's another good reason to make sure that you also talk to the physical therapist, get that permission to talk to their PT to find out how they did and what issues arose and things that need to be of concern and be alerted to. The anterior approach is going to have the least restrictions. for the total hip replacement, but they still should avoid excessive extension of the hip and excessive external rotation. Got to have some time for the hip and the cement and everything, the muscles, everything to heal up. And that can take, 6 months up to a year. So usually the doctor or the PT will say limit this for a year. And and sometimes your clients, when they come to us as fitness professionals, think that it's permanent. I could never do hip extension. I can never do hip abduction. And you're like, gosh, because, that's going to really limit some of your daily activities, much less just exercise movement. And they don't understand that it's a limitation typically up for a year. But after that, now everything's healed up nice and solid, and they can kind of get back into those correct movements. And then the lateral approach to the total knee replacement really has no limitations. Many limitations, like we said, are temporary unless they're stated by the orthopedist. So these are all things that, again, we need to know as fitness professionals. We need to know where they are, how long ago they had the surgery. If it's within the year, then definitely get in touch with their physical therapist and get all the nitty-gritty information to help you, to help your client. So let's look at knee replacement now. So numbers to know, the average age for a total knee replacement is 70. 60% of the patients are female, and that may be related to that valgus that females tend to have, the knock-kneed, where the femur is not always lined up properly with the tibia just because of the structure of a female's pelvis. And activities, if they've been doing a lot of running, jumping activities and we're taught how to do it properly, causing more valgus on that knee joint. By 2030, there are projected to be more than 3.5 million total knee replacements each year. A lot of this is because baby boomers who are currently in their mid-50s are going to be getting older and older, and joints get older and older. And again, it goes back to technology for shoes and equipment, and our knowledge has changed a lot, but the baby boomers didn't get that maybe until later in life, and the damage may have already been started. But there's a 90% success rate after 10 years and about 85% of a success rate that everything's still going great with that joint replacement after 20 years. So it's very similar to the hip replacement. Knee replacements, in my experience, you guys may have had different experiences, but knee replacements are a little more challenging than the hip replacements. I have found, at least with people I've worked with, that they recover a little faster from the hip replacement. The knee replacement, is a little bit rougher in the rehabilitation, mainly because it has direct weight bearing. Shoulders are the worst. But if it needs to be done, it needs to be done. And we just want to encourage our client to do the right thing. So again, predictor of physical performance post-surgery is quad strength pre-surgery. So pre-op is very, very important. So when we're looking at our knee surgeries, it sounds very radical, just knee replacement. I mean, it just sounds scary, but it's really not. And so the patient imagines this huge 3-inch scar on the anterior knee, and they see the staple marks from people who've had it done, and it just looks scary. But it's really kind of close to, like what we were talking about with dentistry, which I don't know if that's a good comparison because people may really hate the dentist more so than the knee. But in the end, this is how I tell clients that are really nervous about getting this done. It's like, hey, look, whatever joint you're having replaced, the cool thing to think about is that damage or that arthritis is literally going to be taken out of your body, and you're going to be feeling better once the rehab is done. You really are. So some things to kind of keep in mind, just like with the knee, there are different types of options, and these are options that you want to discuss with your doctor. And there's also a knee resurfacing, like with the hip resurfacing, very similar. which isn't listed up here, but the knee resurfacing, the thin layer of bone is removed from the damaged surface of the femur, and the removed bone is then replaced by a thin layer of metal about the same thickness as the bone that was removed. And in a similar fashion, the upper end of the tibia is also done, the proximal end of the tibia, and they place a wafer of plastic to replace the meniscus that were there. Sometimes the back part or the posterior part of the patella may also need to be kind of smoothed down or resurfaced with a piece of plastic, depending on damage there. And everything's connected with bone cement, the special bone cement. And when the cement is added, it's kind of doughy and it's pressing into the bone to help create the connection that needs for the attachment. And then after the knee has been replaced itself, the metal cap covering the end of the femur rubs against the plastic that's on the proximal end of the tibia, and they've got a very low wear rate and a very low frictional resistance from these two surfaces. So just like with the hip, that is less invasive, and it may work well for some clients or patients, but sometimes they need one of the ones listed on this page. So your total knee replacement is where the whole knee is replaced. The partial knee replacement is where they only replace the affected part of the knee. So it may be, the right side of the or the lateral meniscus on the tibia, or the lateral condyle of the tibia and the lateral condyle of the femur, or vice versa. And then a bilateral knee replacement is when both knees are replaced at the same time, and that is a discussion to have with the physician as to whether that's a good option or not. So most people get knee replacements because they have an osteoarthritis, and the total knee replacement, of course, is going to be your more common way to go, about 700,000 of them every year in the United States. So the knee replacement itself, the surgeon, of course, is going to remove the bone and the diseased cartilage from the femur and the tibia, and then it's replaced somewhat similar to the hip, that the hip's a ball and socket joint and the knee is a modified hinge joint. So the surfaces are replaced with a metal implant and then a special piece of plastic. If you look back at this picture right here, this is the special piece of plastic right here, this white part, the plastic spacer to kind of mimic the cartilage that was there before, so that it helps to give a nice smooth surface between the metal and the plastic as you flex and extend the knee. So when you're looking at, oh, there you go. There is a better picture. So there's that plastic spacer. There's the bad part of the knee. It's kind of banded down, so to speak, and recut, reshaped. And then here's the, whoops, lost my mouse there. Here's the femoral component. Here's that plastic spacer piece for the replacement of the meniscus. And then the plate that is also hammered and drilled down into the tibia with the stem to hold it in place. And here's your new knee joint. So some things to keep in mind, post-surgical precautions. Most patients spend about 2 to 3 nights in the hospital, again, for the same reasons that we already discussed with the hip. Pain medication is going to be prescribed, and some people take it. I've actually seen some people who didn't, which was amazing. Shortly after the operation, you'll have a PT come into your hospital room and get you up and walking on that knee. Now, they may have a nerve block, and they may think, wow, this is great, I don't feel anything, but that nerve block's going to wear off once they get home, and, so sometimes it's good to start taking the pain medication per the physician's requirements before the pain gets bad. So weight-bearing therapy starts the day of, and then once they're released, they may have in-home physical therapy come in and then eventually progress into outpatient physical therapy. But they really need to make sure they're doing those exercises, just like with the hip. They need to make sure they're doing their home program, or what I call homework, to keep everything nice and strong. So the fat pad removed during the surgery may make kneeling painful after surgery, and a lot of doctors will tell you not to kneel on your knee. Just follow the doctor's instructions, and that may be a permanent modification, not to kneel on the knees directly. Swelling of the knee leads to decreased quad activation, so making sure that they're icing it the way that they have been instructed to do. And keeping an eye on swelling, because that may be a sign of infection. Red, hot, painful might be a sign of a blood clot. So making sure that the incision is properly taken care of, and that, looking at the lower leg itself to make sure that they're not showing signs of a blood clot is very important for whoever's taking care of them. So now they're done with their physical therapy, and we're going to get into some of the exercises for hips and knees. So many of the goals and exercises used for the hip will also be appropriate for the knee as well. So we kind of merge them together because of muscles that cross over the joint. You strengthen the quad, you're strengthening rectus femoris, you're helping the hip, that type of thing. So the goal is to manage strength and range of motion and balance this. Anterior, posterior, medial, lateral to the leg, but also left leg, left hip, right hip. So stability, especially balance, all of that good stuff. And again, they should have a pretty good foundation because they have left physical therapy and they're coming to us. So we also need to improve their walking and get them comfortable. Sometimes they're nervous, sometimes they're scared, and we want to help them with that fear and decrease their risk of falls, because people do some goofy, crazy things to get moving around. I've seen people stand a couple of feet away from a table or a chair, and then they'll let themselves fall forward and their hands tapped on the table in order to move themselves closer to the table, and I'm just like, oh my gosh, that's crazy. So at plus or minus 90 days or so post-op, the client should be at or ready beyond their pre-surgical levels. That's just kind of the goal. Again, it depends on the person and what their situation was prior to the surgery, how the surgery went, and all that good stuff. But it's a good rule of thumb. So before working with your client, and this is where we're really getting into focusing on us fitness professionals, what do we need to do, is get that discharge statement from the physical therapist. Getting it from the client or getting a verbal from the client is not always ideal. They may be trying to do something that their physical therapist doesn't want them to do, so we want to get it from the PT. Exercise with caution, whether it's a hip or a knee. The THR is not target heart rate, it's total hip replacement, or the TKR, the total knee replacement. So we need to exercise with caution for 3 months unless the doctor of the PT says otherwise. And again, that just depends on the client and how things have been going. Be aware of any movement contraindications, such as the kneeling on the knees or the hip movements, the excessive movements for the hip. And assess pain levels. If what we are doing is causing more pain, we need to modify whatever it is that we're doing. And we're talking joint pain. Muscle pain, pain is not good. Muscle tension is normal because they're still using their muscles in ways that they probably hadn't in decades, depending on what was going on that led to their need for a joint replacement. But if it's pain, we need to modify. And if they continue to have the pain after the modification, then we may need to send them back to their doctor. Determine the types of painkillers and antibiotics that are being used and for how long. Antibiotics can pose an increased blood thinning risk for those who are on blood thinners. So they're going to get all that information as to whether they're okay to start doing certain daily activities and exercise from their doctor on those. The painkillers are good to know because if their painkiller makes them loopy and goofy, which a lot of them can, that's probably not a great time for them to be exercising while they're under that influence. If they're switching to less narcotic-oriented type painkillers, even if it's prescribed Tylenol, prescription level Tylenol, then that's probably going to make them less loopy and make exercising safer for them. So we do need to be careful with that. And also when the doctor recommends they take their painkillers, is it before and after their exercise? They may want them to definitely take it beforehand. How far in advance before exercising? I mean, they need to get all this information, and it helps us to be aware of it as well, so that we can ask them about it, make sure they're following those recommendations. Because the painkillers, of course, are going to lessen the pain during exercise. That can be a good thing because your client may be more willing to do more in the exercise session. The flip side of that is we have to be careful about overdoing it because the painkiller is going to be masking pain. So we just need to be aware and be cautious. If there is pain or swelling or inflammation and it's worse than usual, stop the activity, send them back to the doctor. Your client should be improving. So if you're seeing things that are setbacks, that's not normal, and they may need to go back to their doctor. And need to make sure that they have their assisted devices, their walkers, their canes, you know, have it available. We are trying to hopefully wean them off of that, but have it there just in case. Rule of thumb that I've always heard is when somebody leaves their walker, you know, if they go to the store or something and they start moving around without their walker and all of a sudden they get home and they're like, oh, I left my walker or my cane at the store, that's usually a good sign that they don't need it anymore. So food for thought there. So my little segue here into using a cane. Now the physical therapist is already working with them on getting the correct level or height for the cane or the walker, and they need to maintain that because if the client starts messing around with it too much, they may be lowering it to accommodate for poor mechanics that we've already talked about, and we want to change those mechanics. And plus, if they have poor mechanics, then that may put them at a greater risk of falls because they're throwing off their center of gravity. So instead of maybe changing what the PT set up for their walker or their cane, instead, fitness professionals, we need to look at their form and make sure they're walking in correct form, because that may be the problem. So if you use a cane or if the client uses a cane for stability, they can grip it in either hand, whichever feels most comfortable. Pick up and move your cane in unison with the opposite leg. And again, the client should know this, but you may, as a fitness professional, need to reiterate this to them. Don't place the cane too far ahead of them because that's going to throw their center of gravity and their balance off. If they have a disability or an injury, the surgery affecting their hip, knee, or ankle, the doctor or the PT might recommend a specific walking pattern with the cane, such as maybe holding it in the opposite hand from the affected leg. So whatever, you know, again, these are important things to get from the PT when you talk to the PT as the person transitions into post-rehab with us. They need to make sure they're standing up straight, that they're walking naturally, but also walking what needs to be normal. And again, this may be that change in their mechanics that we're working on as well. So these are all things that we need to consider. Wear their usual shoes because the thickness of the shoes is going to affect the height of the cane or the walker. So they need to get the cane or the walker aligned with the shoes that they will normally be wearing for that reason. Measure from the crease of the wrist to the floor as far as the cane and the walker goes because you don't want them leaning on it. And that's going to help give you that optimal height for the canes and the walkers. So for exercises, non-weight-bearing activities first. This is to help restore strength, but also mobility. If your flexibility is limited, that's going to affect range of motion, and that's going to affect how many muscle fibers get involved in that exercise, which ultimately affects strength. So it is a snowball effect. Chances are they got the flexibility and all that in PT, but it's still good for them to continue with it and incorporate it as a quote-unquote regular stretching program for them. So the hips, the knees, the ankles, they all work together for movement and ambulation. Ankles, foundation, so if your ankles are limited in range of motion, that's going to change the mechanics and movement patterns at the knee and the hip. So we start from the base and work our way up. So after they're discharged from physical therapy, the initial goal is to maintain what they've gained and gradually start to improve upon that PT program. So this initial phase usually lasts about 4 to 6 weeks post-op in physical therapy, and then fitness professionals get the client. So with your designing of your program, and this is kind of getting into prehab as well as the post-rehab. When designing the program, be aware of the client's ability to get into that correct position for the exercise. If your client can't get up and down off the floor and you don't have a treatment table that's low enough for them to get on, then you need to find chair exercises or something else for them to do that is still appropriate for them. Also, we need to consider transition from one exercise to another. So if your client, for example, can get on the floor, you don't want to have them get on the floor and do an exercise, then stand up, go do something else, and then have to get back down on the floor, because they're probably going to fatigue, especially early in the program and the post-rehab program and prehab training to begin with. They're going to fatigue before you can even do what you're wanting to do to help them. So, and looking at prehab training, this is becoming more and more a focus in some of these surgeries. It wasn't so much, at least what I noticed, maybe, I don't know, 15 years ago, and then it started kind of, oh, we need to do some prehab training. And who does it depends. It could be a physical therapist, and I think initially it should be a physical therapist to get movement, range of motion, all that good stuff. It may be able, once the assessment's done by a PT, it may be able to move forward into a fitness professional. It just depends on the setup, doctor recommendations, all that good stuff. But like we have said, the stronger the client is before the surgery, the faster their recovery will be afterwards. So we want to try and do as many of these exercises as we can before the surgery to keep the client as strong as possible. And, again, we cannot forget about other health issues that they may have that are controlled through exercise, such as diabetes, heart issues, high blood pressure, that kind of thing. So, we need to keep them moving. How we do it is what we got to figure out. So when we're looking at the functional movement patterns for prehab, looking at walking gait, because it's targeting the whole body and it's an activity of daily living, bilateral, unilateral, lower body pulls. Unilateral may be better because they, focuses more on the weaker side. Get the glute max and the hamstrings. And when you see things like deadlifts and squats, again, keep in mind, we may just be talking body weight. Lower body pushing type exercises to really get those quadriceps. That could be a squat, again, without weight. Lunging to help get glute max, hamstrings, quadriceps, doing forward and reverse lunges. Prehab, because of balance issues, they're probably going to need to hold on to something for balance. Looking at ankle pumps, ankle rotations. This is great before and after surgery because it helps get the blood movement flowing, lymph movement a little bit more mobile. It goes back to what we were saying earlier about starting with the base of support. So looking at ankle movement, gastroc, soleus, anterior tib, the other lower leg muscles, so that they can get that range of motion that they need to use their knee and hip properly. And then looking at quadriceps, can't talk, sorry. So this is a great prehab exercise. It's also an excellent immediate post-rehabilitation exercise, I'm sorry, not post-rehab, but post-surgical exercise, because you're just working on isometric contractions of the quads initially. So all they're going to do is tighten the thigh muscles. Sometimes people are like, huh, what? Their muscles aren't doing what their brain is trying to tell them to do, so they need to get that connection with the nerves again because those nerves may have been cut during surgery. So pressing their knee down, pulling the toes back, those may be cues that you want to use. And that helps to isometrically contract the quads. Once they've got that down, they can start to lift the leg as high as they can. It may not be far, but that's a starting point for them. And you get them to, and if they need to bend the other knee, that's fine as far as helping with their back for positioning. But, you know, just having them hold those isometric contractions for a little bit, because again, nerves may have been cut and they need to kind of be re-educated as to what they used to do and how they used to work together, and that takes time. So this is a great place to start, and then eventually the progression can be in a seated position, leg extensions without a weight, and you can start to add a little bit of weight, and then you can progress into some other exercises that we're going to get to in just a little bit. Another great one for the knee and for the hips, getting those glutes. And because your client may not be able to stand to do some of these exercises because they're waiting on their joint replacement prehab, just having them lie down on the floor, have them squeeze their glutes together and hold for 10 seconds and then drag the heel back, because that will also get those hamstrings. You can put a paper plate underneath there or a glide disc underneath, whatever works. You can put a small exercise ball between the knee and the lower leg and have them draw back and squeeze against the ball to get a little bit of an isometric contraction. And then straighten the leg forward and relax the muscles until you do the next repetition. Then as they start to progress, again, pre-rehab or post-rehab, they've probably done these in physical therapy also, we want to continue it, is to work on clamshell exercises. And with your clamshell exercises, a great exercise to help work glutes medius and minimus. You can do it seated. You can do it lying on the floor if you're able to get up and down off the floor. This helps to work those external hip rotators. You can do it without the band. We've talked about clamshells before, so you want to follow those same procedures. If they're doing it seated, notice that in this situation, the feet do not stay together. This is helping really to get the hip abductors a little bit more. There's not a hip rotation unless they roll the knees out to the side, but it's still a great way for them to gradually work up to maybe getting on the floor or the treatment table to do the clamshell exercises, and use gravity to help them with that. You can do, again, this picture, previous slide, hitting the hip abduct, and again, not external rotation like a clamshell, but it could be a good starting point. But we don't want to forget the adductor. So that's where you can use a ball, whether it's a medicine ball or, you know, even a little spongy Nerf ball initially. Just make sure it's big enough where they can squeeze the knees together without knocking the knees together, that it doesn't collapse so much that now they got pressure on the knee. These are great to start with. Again, with any of these exercises, as far as repetitions and sets go, watch their form. If it looks like it's getting too easy for them, instead of, you can go a couple of ways. You can add a second set and not increase the resistance, or you can keep the sets the same, lower the repetitions a little bit, and increase the resistance. This is kind of getting back into that fit procedure, frequency, intensity, and time. You know, sometimes you just got to play around with it. The thing is that you want to progress the client, but you don't want to overdo. So watching facial expressions is also a great way, besides watching form, to make sure that the client's not fatiguing and losing their form. Seated, sliding, ab and adduction. Great way to work on some range of motion, but again, remember, if they've had the hip replacement, we need to be limiting the range of motion at the hip joint. So this gentleman's going out fairly far. You may have your client go out this far. If they try to go out too far, they're going to start compensating by flexing forward at the trunk a little bit. And that's just a sign that they're going too far and also a sign that they're losing their form. But follow the recommendations if you do any of these. Follow the range of motion limitations that have been given to you by the PT or the physician if they've had that hip replacement. Sliding leg or leg slides, seated leg slides. Again, kind of working on the hamstrings without any resistance just yet. This is a great way to get them started just on some re-education of the muscles. Also a great prehab exercise without a whole lot of resistance. And this is really focusing on the hamstrings as opposed to the glutes because you're not extending the hip, you're just flexing the knee. So that's a good one. And then stair climbing. You know, we mentioned stair climbing, chair press-ups, making sure that they are not flexing at the trunk so that they really incorporate and engage the glute muscles, especially that gluteus maximus. Having them slow it down and, you know, press through the heel of the foot because this is something that can limit whether they stay at home in their home or not if they have stairs and they don't have master floor living. So this is a functional activity that can help them both before the surgery, prehab, and post-rehab after physical therapy. Chair press-ups if they need to use the arms because in prehab their hips or knees are hurting them so badly that they need to use a little bit of assistance with the arms. That's fine. They're still getting something with their legs. And eventually, of course, you want to progress them to where they don't have to use the arms, but that's going to be more of a post-rehab focus. And then weight-bearing activities. So kind of looking at post-rehab especially, and as your client is ready for this, getting the hip hinge glute activation, because again, people don't realize how weak their glutes may be. And this is honestly a good exercise for anybody. But what you're going to have your client do is start against a wall, back against a wall with their stance wide, heels about 6 to 8 inches away from the wall, feet about hip width apart. They're going to perform a 30-degree hip hinge so that if they're doing it properly, then their glutes are going to, quote unquote, kiss the wall. So it's not a lay back and lean, it's a light touch. They want to keep the spine neutral, including the neck. So make sure you can see how she's looking, I don't know what that degree is, maybe 45 degrees or so, but the key is that she's got her ears, shoulders, and hips in a nice straight line. When the form is perfect, execute the move with the knee flexion so the fingers can start to touch the floor as well. But again, they got to keep their form. That's really going to get those glutes set. This is going to help teach them how to pick things up off the floor properly so they're not hurting their back and they're still strengthening their glutes. And then once the finger touching form is perfected, and you can start to add some resistance. You can see she's holding some weighted items to help her increase that strength. So that's a nice progression. Lunges, transverse lunges. You can see, and these are all progressions. This is post-rehab progression. So you can see in this first picture, he's got a band that he's using as resistance that's pulling him back this way, while he's wanting to go this way. So that really helps to work on stability of the hip and the knee. And this other picture is like, what the heck is this guy doing? And really what he's doing is he's starting facing you, and then he is rotating one leg out to turn almost like a sword, you know, the unguard. So you're facing in one direction and then the leg in the direction that you're going to turn to. So if you're turning towards the right, it's your right leg that steps out and externally rotates and goes into a lunge. Okay? So you're standing with the feet hip width apart, holding a dumbbell if you're ready for that. And you're going to keep the left foot planted, pointed in a straight line, like at 12 o'clock if you're using clock directions. And then while stepping back and out to the right with the right foot, you're going to rotate the right foot and place it like at 4 o'clock if you're using clock directions. As the right foot hits the ground, push back into the right hip while reaching for the right foot with both hands. If they want to get to that point, that's a progression, but at least have them lunge into a good, correct lunge, going as low as they can go correctly, and then push off the ground with the right foot and return to the standing starting position. Those are great transitions, multi-directional, multi-plane movements. Then, of course, your forward step up, your lateral step ups. The lateral step up over here can also be just a straight lateral step up where they're just stepping in the frontal plane, or you can combine it with that transitional step up that we were just talking about just a little while ago. That would be a progression. This is going to help them with stair climbing, getting the glutes activated, making sure that they don't lean too far forward with the trunk, because that is going to lessen the activation on the glutes and put a lot of pressure on their back. So form is key. And then your sit to stand exercises. Now this kind of cracks me up. It's like, okay, what happened here? But she may not need it. She may not be ready for it yet. The other people might be. Again, you know, just individualize it. But using the bands to help keep the medius and minimus activated for stability. That's where those bands come into play. And you guys have probably used it on other clients. And then make sure that they aren't flexing too far forward. Again, you know, we want this to be a glute and quad movement. So asking open-ended questions. Where are you feeling this, the muscles? Where are you feeling this? And they have to think about it to give you a good answer. Instead of saying, hey, are you feeling this in your buttocks area and in the front of your thigh, they're going to go, yeah, whether they are or not. So instead, ask them, where are you feeling this as you do this? And you'll get a lot better information as to whether they feel like their form is correct and you feel it's correct. Your hip hikers, using a pole or something here, a cane or whatever for balance. It needs to be kind of tall, so maybe not a cane. And you have one foot on the bench and one foot hanging off the bench. And what you're doing is, in this picture here, you're lowering the leg as close to the floor as you can. It's probably not going to touch. It might, who knows. But you're lowering as far as you can so that the hip is moving, but shoulders and everything are staying in alignment. And then you're lifting back up. This helps to work glute medius. It also helps get quadratus lumborum, that lower back muscle, which is kind of the hip hiker muscle, to help keep that strong. Because again, compensations may have left other parts of the body weak, and back pain is a big complaint when people have had knee problems because they're compensating in some way. So this will help strengthen that back muscle as well, one side at a time. And then your standing band triple flexion. This is the triple flexion part is going to be at the hip flexion right here, knee flexion, and the dorsiflexion of the ankle. So this is getting you know, helping with movements for walking and walking gait. It's also helping to strengthen these muscles for squatting activities and range of motion. So this is a great exercise. You can start them off without the band and then progress them to the band. And again, band resistance can be modified as well. And then balance training. This is a fun part to me because you can really get creative as long as you're safe. You can create little obstacle courses if you have taken the balance training programs through Exercise, etc., or other courses for your older adults. It just makes it fun. And, you know, using all kinds of things they can step over. I mean, you don't even really have to buy anything fancy for equipment. We used the flyer brochure stands, those plastic stand that you can stick a flyer in and have at your front desk for announcements. We would use that to have clients step over them. You can use mats just to have them walk on the mat because it gives, so it can kind of help them, work on their balance. All kinds of creative things that you can do. Painter's tape I love because first of all, it comes in all kinds of bright colors, so if they have any vision issues, they can see it pretty easily, possibly. It also doesn't leave sticky residue if you have carpeted areas, so it just comes right off. And you can create all kinds of little designs and triangles and squares and things where they have to turn or angle and pivot and switch directions. All kinds of things that you can do. And this is going to help build their confidence so that they do maintain form during their activities of daily living and reduce their risk of fall so that they don't end up falling and having to, either having another injury or having to go back and get that joint replacement fixed because now there's been some damage. But there is a whole other lecture and presentation on balance training that you might be interested in. And then using some leg stance drills, aluminum can drills, because now to me this makes me think of walking on ice. Being a Southerner, I don't know how to do that. So you've got that one foot that's kind of feeling like it's rolling out of control, but they got strength, and this is deceleration of muscles to help stop that. So this is a gentle way to start having them work on deceleration drills or eccentric contraction drill. And then some advanced options to start progressing them to one-legged activities and have them stand starting off first on a stable object and then progress into unstable objects. But while they're doing this, they can bat a balloon. They can play volleyball with a balloon because it's amazing what people think they can't do. And then when they're playing a game, like a child's game, all of a sudden they're doing things and you're like, hey, you just did that lunge. Hey, you just moved that shoulder, so it makes it fun for them too. Playing catch, you can have them move their head up and down. You can have them move their head side to side. They can turn where everybody's left arm is facing the center of a circle, and now they have to turn their head to throw things, and then switch because that helps them work on balance. Because one of the things you notice for a client who has balance issues is when you're walking side by side, they never turn their head to talk to you because that will throw them off balance. And so now you're helping them to work on that because those muscles need to regain the re-education of what they used to do, and balance is a part of it. And then, of course, progressing them to a variety of walking drills without support. And in this picture, you could take this picture all kinds of different ways. Maybe the woman is the caregiver, and she can have him walking without his walker for a little while, and then as he gets tired, he can walk with it. The nice thing about these, they're called rollators. Is when the client does get tired, they can sit down and relax a little bit. So that's nice. We don't want them to do that too much, but that's a nice option. You can get them into ladder drills. They can do it with their cane or their walker, actually their walker, then progress with their cane, and then after they're able to do some of these previous balance activities that we were talking about, then you can have them start doing walking drills, stop and go activities, deceleration without assistive devices, and really help them get back to their living. And again, we've got lots of presentations that delve deeper into these topics. We have some other presentations that do that if you're interested. So you made it 2 hours. I hope it was exciting for you and you got some good ideas. So remember to get your certificate immediately following this webinar. If you've completed it, just go to exerciseetc.com, click on the administration button at the top right of the screen, and then click on the webinar on demand certificate link. Choose the exact title of the presentation, and again, the title of this presentation is The Bionic Elder, Training with New Knees or Hips, and complete the 20-question quiz that's required. complete the brief evaluation, and once you've done that, it will take you to the field where you start to fill out your information on your certificate. Make sure when it's emailed to you that you save it and hang on to that for your credentialing organization. And also remember to complete this webinar and print off your certificate or save it December 30 or by December 31st, the same year you purchased it, since some organizations may not accept it if it has next year's date. And that is the end. I hope you enjoyed it, and hope you enjoy working with your clients in this area.